All right, good afternoon, everyone, and thank you for joining us for tonight's Woo You event. We are going to get to hear from the one and only Dr. Ben Gaddie on treating the newly diagnosed glaucoma patient. I'm your host tonight. My name is Dr. Ariel Serenzi. And then I'd like to introduce our speaker for tonight, Dr. Ben Gaddie. I'm sure some of you guys have heard from him before. He's been on Woo You. But is this your third time or fourth?
I'm not sure. I can't remember. At least the second or third.
Right. So we love hearing from him, and he's an expert in the field of especially with glaucoma. So I'm gonna go ahead and have you take it away from here. Oh, we got to do your. We'll go to the next slide there. And there are his financial disclosures, all of which have been mitigated. And I will let you go ahead and take it away from here.
All right. Well, thank you, Dr. Serenzi. And I'd like to thank Dr. Wu. Stephanie has done such a phenomenal job with this platform. Every time I'm on it, I'm more and more impressed with, I think we have somewhere close to 1,700 doctors registered this evening. So that's certainly an honor and a privilege to share a little bit of my glaucoma knowledge with you today for this continuing education credit. So the title of the talk is, how do you treat the newly diagnosed patient? And I think our profession's come a long way since I started treating patients in 1997. I think optometry accounted for roughly 8 to 10% of all glaucoma prescriptions written. And now today, if you take, for example, the prostaglandin class, we're getting up close to 40, in the mid 40% of all prescriptions. So it's quickly happening. It didn't seem very quick to me over the last 20 plus years, as I've spent a good part of my professional career advocating for not only the scope of our optometric colleagues, but to utilize that scope. And I can't think of a better example than treating the newly diagnosed glaucoma patient. Because look, if you can write a prescription for a prostaglandin analog, you've really gone a long way to starting a patient on glaucoma therapy. And there's obviously going to be some exceptions to that rule, but I like to say that I don't think anyone could really get too hurt with the prostaglandin. So if nothing else, when you walk out today, I want everyone to feel confident in making that first and maybe even contemplating that second medication. By the way, when we look at prescribing data of our colleagues, again, most of our doctors today are very comfortable with that first prescription. But where it really drops off is in the adjunctive, when we have to add a medicine, a single adjunctive agent, a combination agent, maybe adding laser or some other type of surgical route. That's where we really fall down a little bit in terms of having some anxiety about that second prescription, not really sure what to do. So we'll get to that a bit later as well. But I'd like to start this journey of talking about starting glaucoma treatment, talking about target pressure, because look, if you don't have a roadmap for where you're going, you're going to look up one day, and this happens to me occasionally when I fail to identify a target pressure is, you get 10, 15 years down the road of treating a patient and you stop and you go, am I being successful in what I'm doing? Are we making an impact? So what does that mean? Have we lowered the pressure to a level where there's no further progression, right? And that's where, if you don't set a target pressure, you might go back and say, I can't even remember what this patient's pressure was when we started. So I go through a lot of painstaking maneuvers with my record keeping to make sure that I know, where did we start? What was the highest pressure? And then what is my target for the pressure? And it's not the same for everyone. It's practically kind of the same. But overall, we have different goals for different situations that our patients are in the glaucoma journey. So this was the Optometric Glaucoma Society has, which by the way, still on the board of. I was a president for about 7 years. We're part of the Worldwide Glaucoma Association, which includes the American Glaucoma Society, the Japanese Glaucoma Society, every basic developed country, and some of the undeveloped countries participate in the World Glaucoma Society. So We're very proud to be a member society of that. And some of our education, we did some polling. You can see this is 15 years ago, but still, we asked 108 participants what they do about target pressure. And as you can see, about 10% don't set a target pressure. Another 15% set one, but they don't really record it in their notes, which means they didn't really set a target pressure, because unless you're just like a complete savant and you can remember every patient, what their pressure was and what their target pressure is, if you're doing that, you need to be counting cards in Vegas and not treating glaucoma. About 25% of doctors set a target pressure, and they sometimes record it in the patient notes, which to me means they're probably not actually setting one. And then 50% say, I set a target pressure and I always record it in the notes and I always go back and refer to it. And, that's kind of what I see. It's about 50-50, write it down in their chart. So for me, I think there's a clinical legal aspect to this. If you have a patient and you're, otherwise treating that patient in earnest, doing everything right, but let's say they go blind, and you're in a lawsuit and you're sitting up on the stand and the attorney's saying, well, doctor, what was your plan for this patient? You were treating them, but how did you know your pressure was low enough? What kind of guidelines did you give yourself? And when you don't have a target pressure recorded, I think it could be problematic. The other thing, that if you're not comfortable putting a number in there, put a percentage. And that's what I really like to do. I look at a patient, we'll talk about this in a minute, and I look at their risk factors. We're just diagnosing glaucoma. Is this a moderate, a mild, or a severe patient? And that really drives a lot of my decisions. So where do we get some of our guidance on setting that initial target pressure? Well, our landmark clinical trials in glaucoma, our alphabet soup of glaucoma trials. And you can see we can take data from the ocular hypertension treatment study, which looked at medical treatment versus observation. We can look at the emerging manifest glaucoma trial, which looked at observation versus treatment. You can look at the collaborative normal tension glaucoma study, which was, medication or surgery versus observation. The collaborative initial glaucoma treatment study. So these are patients in NEI funded that just got diagnosed and they were randomized to receive medical drops versus surgery. And then the advanced glaucoma intervention study, which looked at ALT versus surgery. And what these did is as part of the studies, they had to set a target by which the patient, was able to continue in the clinical trial or not. And that's where we're able to draw a lot of our conclusions on what we should do with our patients. So in the OATS study, it mandated a 20% reduction for those patients that were actually treated. And what they found was that treatment, pretended a protective effect. So 9.5% of patients in the observational group progressed from ocular hypertension to glaucoma, whereas only 4.5% in the treated group. Now, a lot of knocks potentially on the OATS study and people with ocular hypertension and not really glaucoma. For me, if I have an ocular hypertension patient, I'm just trying to lower their pressure to a safe zone, right? I'm not like worried about, oh gosh, if I don't get to 13, they're going to progress. I'm just trying to keep them out of the woods. In the early manifest glaucoma trial, their goal pressure was 25%, and that was the mean average. And you can see in the patients that didn't receive treatment, 62% of them progressed in early glaucoma patients, whereas only 45% of those patients that got at least a 25% reduction progressed. And you can go on down the line and look that, consistently low pressures lead to a reduced rate of progression. And despite all the advances we've made in glaucoma and all the research and innovation that we have, at the end of the day, lowering pressure is the primary thing that we have, the only tool we have. And so everything looks like a hammer. So the question is, how low do we need to go? In the advanced glaucoma intervention study, which is up on your screen now, I'd like to show this graph. And this is really looking at progression, all right? And you can see the mean change in the visual field defect score on one axis, and then the follow-up in years on the other axis. And when you look at patients that 100% of their time, their pressure was less than 18. Now, 18 isn't like a big aspirational number for a goal pressure. Like I think most of us are probably going to want a goal pressure less than 18, regardless of where the pressure started. you can see that those patients that were well controlled and stable, 100% of the visits less than 18, they did not progress, even with advanced glaucoma. Now, the mean pressure at all those follow-up points was about 12.3. So again, for me, I want the lowest pressure possible at the most consistent number of time points. So when we determine the target IOP, how do I do it? I've got a lot of different ways that people have proposed over the years. But for me, a lot of it has to do with the efficacy of our primary agents, which we're going to talk about today. And that is, I expect with the prostaglandin class, somewhere between a 25 and 35% on average reduction in pressure. And a lot of the association, the American Academy of Ophthalmology, the AOA's clinical guidelines, they talk about a target pressure being somewhere around 20 to 30%. Well, for me, I think 20% is it's just not good enough. I mean, with the medications that we have, and we'll look at some of the efficacy, there's no reason that we shouldn't expect a 30% reduction. So for me, that's just kind of like, you got to meet that 30% goal, that bar in order to play in my game. And then the second part of it is really looking at the amount of damage. Baseline IOP is important, corneal thickness is important, all those risk factors are important. But when you have someone that has significant RNFL loss and significant visual field loss, especially in the paracentral region at diagnosis, those patients are by definition advanced, and they need probably more like a 40 or a 50% reduction in their intraocular pressure. Life expectancy is a tough thing. If you look at actuarial accounting and what they do, if someone is 50 years old, their life expectancy might not be as long as someone that's 70 years old, because someone that has reached 70 has gone through a lot of stuff. Like, they have beat a lot of the odds to get to 70. So the chance that their life expectancy could go to 80 is pretty likely. But if you have somebody that's 50 years old, their overall chance of making it to 80 probably isn't as high from a percentage standpoint. So the hardest thing for me to do is when I have a patient in the chair, they're 93 years old, they're on maximum medical therapy, they need a surgical intervention. And we've already done laser, we've done everything we can, and they need a tube or a shunt or maybe something like a Zen, a middle ground between a MIGS and a full-blown glaucoma procedure. But do we really want to take someone who's 93 and subject them to general anesthesia and all the risks that are inherent to it? And I sit there and I look at these patients, a lot of them, they have their faculties, they have their mobility, they're really quite healthy 90, 85, 95-year-old patients, and I want them to have a good quality of life. So, just because someone's 80, you can't say, oh, they're only going to live a few years. We don't really have to treat as aggressively. Let's just, hope that their eyes outlive their body by a few seconds. And then we look at other things like, severe damage in one eye. Mom and dad went blind from glaucoma. These are all things that really make me want to treat more aggressively. So a couple of things that have been thrown out here. These are just rough, rule of thumb type guidelines. But if you have somebody this is based on visual field loss and IOP with mild visual field damage and a pressure of 20, then a 25% reduction would be in order. However, if they were severe and their pressure was 30, we want a 50% reduction. I don't know that I really try and make a matrix like this in my mind. I'm really looking at the pressure and looking at the amount of damage. Same thing could be said based on the severity of damage of the optic nerve. You get an idea, the more advanced the damage, the higher the pressure, the greater the reduction in IOP. So for me, just as a general rule of thumb, if you were someone doing an externship or a residency with me, we would talk about the fact that I really expect a 30% reduction in pressure with today's prostaglandins, even the generic ones. We expect a 30%. But let's say someone has advanced glaucoma at diagnosis. They have a pressure of 30. They have a central visual field defect and they're 62 years old. Like 30% is not going to do it. So the more advanced they are, if they have central visual field defects, if their pressure starts over 30, I want a 50% reduction. And the fact of the matter is we're probably not going to get there with one drop. Some of these glaucoma prostaglandins and rho kinase inhibitors, they can really drop the pressure 50%. And you will have patients that are super responders. But you have to realize that someone that needs a 50% reduction that starts at 30, a prostaglandin might only get them to from 30 to 20. So you know in your mind, you're probably going to need a second agent. And what I try to avoid is starting off with multiple medicines. Like, let's start with the most efficacious, the PGA, bring the patient back in a month. And if we went from 30 to 20, that's great. At least we got 10 millimeters. Now I'm going to decide what the adjunct or the laser or whatever we're going to do to get them to that 15 millimeters or the 50%. So again, don't try and kill the elephant, eat all the elephant at the first visit. Put them on that one drop. Sometimes you'll get a 50% reduction. What we found, though, over time, and a lot of the adherence and compliance researchers have shown that our glaucoma patients are just terrible about sustaining their medications, about refilling their medicines. I read a stat somewhere around 50% of all people started on a PGA have not done more than 6 refills on a monthly basis after 18 months, meaning we're starting them and they're falling off of therapy because they don't understand the importance of why we're treating them. And that's really on us, I think. But to that point, if looking at this study from 6 managed care plans on the West Coast 20 years ago, they found that in mild glaucoma, of all these patients that have been seen, over half of them, their visits, their pressure measured over 20, and about a quarter of the visits, they were over 24. So these are patients that are being treated, but they're not being treated very well. I mean, you think you're doing a great job because you have them on a pressure lowering drug, but when you step back and look at where you started and where you are, you would recognize that you're really not anywhere close to where you need to be. And that's both on the provider and the patient. So with that preamble on target pressures, I thought I would talk about, today's treatment algorithms. And you can see I made this chart for a publication back in 2017, some 6 years ago. But it really is still in the same place that it was, unfortunately, in 2017. So if you look up at the top box, you will see primary therapy. And to me today, that's either SLT, and we'll talk about that in a few minutes, or a prostaglandin analog. Are there times when I start with something different? Absolutely. A good example would be someone where we're only treating one eye. It's not very common, but it does happen. And if someone has blue eyes and you're going to just treat one, we get concerned that maybe you'll have one blue eye and one brown eye. And so aesthetically, that could be a problem. And I'll show you exactly what that looks like. The other is if you have some contraindications to PGAs, which are not very, very frequent at all. But I have had patients when I introduce the PGAs and talk about the side effects before I prescribe it, they get really anxious about it. And they say, I don't want a drop that's going to make my eye turn colors. I don't want my eyelashes to grow, usually men. And so maybe a beta blocker or a combination agent would be appropriate. But I would say for the vast majority of what I do today, it's a PGA or SLT. So as you can see, we start with one of those. If we get to target, great. We monitor, every 3 to 4 months, their pressure, their visual fields, their OCTs. If we don't get the response we want, then I consider, if I start with a PGA and I don't get a great response, then I will talk to the patient about doing SLT and vice versa. I've got to tell you, for me today, after being involved with SLT for the last, 20 plus years, it's become a lot easier to recommend SLT because I just have so many success stories of people being treated with primary therapy that make it 3, 4, 5, 6 plus years without having to take a drop. I know that seems, just obscure or maybe not believable, but when you have patients that are able to have their glaucoma controlled and they don't actually have to do anything, that's pretty darn good, as we've talked about the pitfalls of compliance and adherence. And really, when you look at glaucoma in general, there's 2 big trends that I see. One is that we want to place the treatment at the site of the disease. So with laser SLT, of course, we're lasering the trabecular meshwork. But with some of the new treatments like Durista, where you inject the medicine into the eye, And it's about, the concentration of that pellet's the same concentration of one drop of omadaprost, yet it can last 1 to 2 years. We think it's because we're placing that drug directly on the iris ciliary body area in the angle, and that therefore the drug is directly interacting in the angle. So everything is targeting the angle, and we think that the main source of resistance in glaucoma is in the trabecular meshwork. It's really the site of the disease. It's not so much of producing too much aqueous fluid, it's a resistance problem. And so as we look at some of these agents, you'll see that we are starting to target in our medications and our pharmacology, the trabecular meshwork, and then all of our surgical and MIGS and everything else also targets that. So that's a big area that we'll go back to later on in this talk. So once we've run the gamut of PGA and SLT, and we're still either not at target or we're experiencing progression on the visual field or the OCT. That's when we start going into this bottom tier of adjunctive agents. And we have the single agents in the blue on the left, beta blockers, alpha adrenergic agonists, and carbonic anhydrase inhibitors. And then on the right, we have in pink the fixed combination, which are COSOP, beta blocker, and a topical carbonic anhydrase inhibitor. Combigam, which is a beta blocker plus an alpha adrenergic agonist, and then Simbrinza, which is the topical CAI and an alpha adrenergic agonist. So that's one that does not have a beta blocker in it, and I find myself using that. It's not uncommon that I have a patient that has COPD and asthma and third-degree heart block. I live in Kentucky. And sometimes you just can't use a beta blocker, and Simbrinza is nice to have. Now with the rho kinase inhibitors, we also have the combination of rho kinase plus latanoprost and rocklatan, and then the other single agent we would add on there is Ropressa, or the rho kinase inhibitor on the left. So with that maximum medical therapy, you can see for me is 3 medicines, 2 bottles plus laser. We get past that, I'm just praying they have a cataract. I'm trying to talk myself into them having a cataract so that we can get that out of the eye, get some type of eye stent, the hydrus. There's so many different options today, goniotomy, dual blade. But to me, it's a travesty of someone with glaucoma to have cataract surgery and not have that addressed. So that's kind of the world as I see it in the medications. So let's talk about a couple of medication classes that are really important. The first we'll talk about are the prostaglandins, and as you can see, they're part of the lipid family of receptors in the eye. That includes the cannabinoid receptor class, prostaglandins, and then prostamides. And bimatoprost or Lumigan is technically a prostaglandin in class, but its chemical designation is that of a prostamide. What are the prostaglandin analogs that are branded that are still mostly available on the market? Xalatan, the original latanoprost, Travatan Z, which is 0.04% travoprost with a Sofzia a buffering system. Lumigan started at 0.03. Now we have 0.01. And then we have Xioptan, which is tafloprost, which is non-preserved. It comes in a vial. We also have a couple others, which I'll get to in a minute, one of which is Zelpros, is a branded latanoprost made by Sun. Unfortunately, I found out this week that they have had a manufacturing problem, and that drug is going to be unavailable for the foreseeable future. So another one bites the dust. Latanoprost, in and of itself, it's been around since 1996 when I was finishing my training, and it's been a godsend. The biggest leap in innovation and efficacy in glaucoma care since Timolol was invented by Tom Zimmerman in 1985, 1986. It's a once-a-day drug, and it lowers pressure 25 to 35%. So as you can see, if you're taking the test, this may be an important point. Latanoprost is a selective F2 alpha agonist. So it's an FP receptor agonist. And these receptor sites are in the ciliary muscle, in the epithelium, in the sclera. And that's important because on the ciliary muscle is where the prostaglandins and their FP receptor sites have their main chemical interaction and mechanism of action. Once the FP receptor sites have been activated, it upregulates the matrix metalloproteinase expression in the ciliary muscle face, and it basically spreads apart. As it activates, it kind of remodels that matrix, and it pulls apart places in the extracellular matrix, allowing the fluid to percolate through the face of the ciliary muscle, which is the pathway to the uveal scleral outflow mechanism. So again, what these drugs are doing is not necessarily targeting the trabecular meshwork outflow system, but they're targeting the uveal scleral outflow mechanism, which is not used very often in a normal eye. It's about 5% of outflow. But when you tap it in a glaucomatous eye where we have a resistance problem, it has an exponential effect on the intraocular pressure. So here's a sample of ciliary muscle that's been stained with a dye for the FP receptor sites. So wherever you see those little yellow dots is where the prostaglandin would bind and activate and cause that kind of spreading and stretching of the ciliary muscle. And that, again, allows for the uveal scleral outflow. So what's new in prostaglandins? Well, this guy right here rules my life. I'll be honest with you. I try like the Dickens not to have my patients on this medicine. The generic form, there are some 9 to 10 different manufacturers. You can see this is Greenstone, which I believe is Bausch & Lomb's generic manufacturing arm. Alcon has their own, Allergan has their own. And then, of course, we have all the other players in the market that are not in the ophthalmic industry that know how to take bulk latanoprost and make it into a solution. So you can get variability. Not to say that there aren't some good generic latanoprost, and not to say that I don't have a ton of patients on generic latanoprost. But if I have my druthers, I want to use, first of all, I want to sample. I want to see what kind of reaction I'm going to get. So today, the main 2 branded PGAs that I have access to are bimatoprost or Limagam 0.01 and Vyzulta. Because if you look at the other drugs on there, they're just not being supported by anyone, or the companies that now own these assets are not they bought them probably at a discount and are looking to just kind of milk the volume that's out there. They're not looking to promote or advance it. So I like to use a branded prostaglandin, bring the patient back. If they have a great response, I try and prescribe it. If I can't get it covered, then I have them go on generic latanoprost, and I have them back again because I need to make sure it works. And let's say I got a 40% reduction with a branded one, and then on the generic, I only got a 25. Well, that's a pretty good reason. I mean, I'm going to add a second medicine to get to the efficacy of my primary branded medication. That just doesn't make sense to have patients be exposed to the frequency of dosing, the cost, the side effects, all the things that we despise about treating glaucoma. So that's that. But now we have a lot of different manufacturers. Sandoz makes a lot of generic eye drops. We now have travoprost, 0.04% generic. We have bimatoprost, 0.03% generic on the market. So our patients are likely getting a runaround when they go to the pharmacy, to say the least. So this is a patient that's on latanoprost, or a PGA, I should say, in one eye. And I'll let you look at it for a minute. And, if you're watching this with your spouse, maybe act like you're watching Jeopardy and shout out which eye it is that's on the PGA. And I think we'd all agree it's the left eye. And it's pretty easy to see that because the iris color change, you can see how much darker the left eye is than the right. And listen, if you were to take pictures of all your patients going on a prostaglandin before they start, and then 2-3 years later, you would notice no matter the eye color, even brown eyes get browner. They get darker in color. The other thing that you'll notice is the eyelid. If you look at the fold in the eyelid itself, where the levator muscle would be pulling, you can see in the untreated eye, you have a nice crease all the way back. You can kind of delineate that crease all the way across the upper arch of the globe. If you look at the left eye, on the other hand, you'll see that it's recessed. That crease is kind of recessed back under the brow. So that's called deepening of the eyelid sulcus. And what happens with PGAs is it just kind of eats away or dissipates the fat, the orbital fat, and the levator doesn't have anything to really grab onto. So it's not like a mechanical ptosis. It's a prostaglandin ptosis. A lot of these patients have eyelash growth, and you can see a little bit of darkening in the eyelashes left versus right. Excuse me. And you take all those things together and you look at the actual palpebral opening, the left eye, you can't see any sclera superior or inferior, whereas when you go to the right eye, you can see a lot of sclera there. So I could go on and on about a lot of subtle things here, but this is what happens when you treat somebody in one eye, and this is what happens in both eyes. And a lot of people start to tell you that their friends and relatives may comment that their eyes look like they're sunken in, that they're hollow, that maybe they're, like they have a black eye or a shiner. And this is just kind of some of the effects of prostaglandins. Now, this is Vyzulta, latanoprostene Bunad. This is one of the newer agents that is developed by Nycox and marketed by Bausch and Lomb. And Bausch and Lomb's had this asset for some 6 or 7 years now. But what's different is not only is it latanoprost, but it has a nitric oxide component that works directly in the trabecular meshwork. So this is one, again, where I do have samples. So it's nice to be able to trial a patient on a branded PGA. But it also has this extra effect in the trabecular meshwork that I kind of like, and I kind of like the concept of. So here's what this looks like. It has a green or a teal top. That could be a test question if you're having to take the test. PGAs have a teal cap. Again, it has some activity within the trabecular meshwork because it donates a nitric oxide molecule. If you haven't thought about nitric oxide, what does it do? It relaxes smooth muscle contraction, a vasodilation. And if remember my grandfather had, chest pain, angina, and he would take a nitrate under his tongue and it would dissolve and it would immediately relax those vascular smooth muscles and blood vessels. Well, same thing in the trabecular meshwork. We think that there are adhesions and contractions within the TM, and this nitric oxide really goes in as a quick hitter within the TM, and we think has another effect. If you look down here in the bottom left of this graph, you see rho kinase as well, and actually nitric oxide and rho kinase both work on pretty much the same signaling system, just one is upstream and one is downstream. So when this drug hits the eye and gets hydrolyzed through the cornea into the anterior chamber, it's broken into two moieties. On the left, it gets cleaved into the latanoprost acid, which we're used to seeing. And on the right is the butanediol mononitrate, which is the nitric oxide moiety. What does this do relative to, IOP? Why should I care? Well, at the end of the day, I want the pressure down as far as I can. And they did a study comparing it to the original branded Xalatan, not latanoprost. And you can see on average, 42% of patients in the trial when they went to Vyzulta, got 2 or more millimeters of pressure greater than Xalatan, all the way up to 20% got 4 more millimeters better than branded Xalatan. So you can see it's not going to be everyone, but there's a lot of patients that will benefit from this activity in the trabecular meshwork. Looking at side effects, really look at conjunctival hyperemia, 5.9% compared to most PGAs, anywhere from 20 to 60% hyperemia rate. So I do like the tolerability. This is a case, a 63-year-old man worked in the Middle East for an oil company. He had a really dangerous job. He got shot at all the time, as you can imagine. And he only came to the States like once or twice a year. So I first saw him a few years back and his pressure was 20 in the right eye and 30 in the left. He had normal gonioscopy. The pachymetry was a little low, 531 in the right and 567 in the left. So you may say, hey, that 30 pressure is because he has a thicker cornea. Well, in fact, that's not the case, because when we look at corneal hysteresis, you can see in the right eye with the pressure of 20, it's 9, and in the left eye, it's 5. So with hysteresis, I'm not going to get too much into this, but it's like corneal thickness, as it's a biomechanical marker, and a normal value is over 10. So the 9.1 in the right eye is suspicious, but the 5 is really, really low in terms of biomechanical integrity. When you look at the OCTs here, this is a Cirrus OCT. You can see that the nerves are really small. They're myopic in appearance, but the nerve fiber layer thickness, the diagnosis is 65 and 58 microns, which is really low. And when you look at the ganglion cell layer, the macular vulnerability zone, you can see that looks like the cells have been cut off with an X-Acto knife. And when you see this, this means the patient's at risk or probably is likely going to develop central visual field loss. And sure enough, you can see that both eyes do have central visual field loss, and that's because of that macular finding. So this patient has advanced glaucoma, pressure of 20 and a pressure of 30 in the left. Central visual field loss, I want at least a 50% reduction. So we started the patient on travoprost and got from 20 and 30 to 10 and 13. I mean, that's phenomenal. That's greater than 50%. And this is what you can sometimes see with prostaglandins. So it seemed too good to be true. Brought the patient back 6 months later, still doing pretty well, right? 14 in the right, 16 in the left. We're at 50% reduction in the left. In April of 2020, he decided, it's just too much in the middle of the desert at 120 degrees to try and put in eye drops every day. So he wanted to know if we could try laser to get him off of drops. And sure enough, we did laser and got to 12 and 15, stopped the drops. We had thought we were doing pretty well. So we went from June to August, and now the left eye has shot back up to 25. So we know this left eye is going to be a problem. We restarted a prostaglandin in the left eye and only got to 21. So, we know right away that this left eye, we're going to be at risk of losing vision and having progressive vision. So I thought, before we go adding adjunctive drugs, let's try and switch that left eye to Vyzulta from Lumigan. And we got to 15. And as of May of 21, we stayed at 15. So again, I always try and if they're on a generic, let's get them on a branded. If they're on a branded, let's try a newer innovator drug to see if it's not doing the trick, let's try the next step. And for me, after we get through the prostaglandins, you can do one of two things. If you need more efficacy, you can add a beta blocker, an alpha agonist, a topical CAI. You could even do a combination medicine. But for me, more and more, I didn't have a good start. We didn't have a good first few dates, but the Rho kinase inhibitors are growing on me. And I'll tell you why, because when they work really, really well. And when they're tolerated, they work really, really well. It's not unusual to see, 40 to 50% reduction, even from someone that's already on treatment when we add a Rho kinase. So we'll talk about some of that in just a minute. But the Rho kinase inhibitors were developed by an ophthalmologist, David Epstein. And what they do is they inhibit the protein Rho kinase. And Rho kinase gets involved in the trabecular meshwork with the skeletal effects. So first of all, it works on actin-myosin contraction. So if you have activation of Rho kinase, it causes extracellular matrix production, increase in cell stiffness. It also leads to adhesions within the TM. So again, I've been talking about how we need to target our treatments to the trabecular meshwork, and we talked about nitric oxide. Now, Rho kinase is the next drug that truly targets the trabecular meshwork. So what happens when you have Rho kinase activated, which is when the system gets upregulated, it just starts producing Rho kinase proteins. And what you can see is they wrap around the actin and myosin fibers within the TM. And once they adhere, these proteins adhere, they cause adhesions to the extracellular matrix, and you begin to get a sticky or non-penetrable trabecular meshwork. And that's where the long-term damage in the TM comes. If you were to take a patient that's had glaucoma for 30 years and they were to pass away and you got to use their eyes for science, and you pulled out the trabecular meshwork and put it under a microscope, you would see that there's almost no ability to penetrate the tissue because of all these adhesions. So what the rho kinase inhibitors do is they actually go in and break these focal adhesions. And once they break the adhesions, this allows for the restoration of the trabecular meshwork. Now, for me, I've been reading and following a lot of studies that are looking at things like every year getting low dose SLT. So you could think about doing SLT and then going in and using something like a rho kinase inhibitor to help keep the trabecular meshwork from having these adhesions in the future. Here's the problem with this class of medicine is the side effects. And literally, I forced myself to use it because I had enough phenomenal results that I told myself, look, 50% of patients are not going to be able to tolerate this medicine. 50% are, and I need those 50% that are going to be able to tolerate it. So when I'm contemplating using it, I tell the patient, look, your eyes are going to look horrible. They're going to be red. They're going to look the worst. Whatever your PGA was, is nothing compared to this. And I tell them that because when they come back a month later and I walk in the room and I look at their eyes, most of them don't complain about it because I warned them how bad it was going to be. But I still have probably 25 to 30+%. It's just too red. They just can't handle it. But for those that can tolerate the redness or don't have very much redness, again, you can see the conjunctival hyperemia is 54%. So roughly 50% are not going to have hyperemia. And for those patients, it's been a godsend. It's kept so many patients from needing trabs and tubes and everything else that I feel compelled to, at least on my patient's behalf, try it before I move on to other, more invasive therapies. The other thing this drug causes is corneal verticillata. And if you have patients that use any pace-related cardiac drugs, pacerone, amiodarone, they leave this verticillata. And this drug is, you can see about 20%. In my own experience, to using a lot of this particular product, I think it's got to be higher than that. With that being said, they've shown in different studies that the verticillata doesn't cause any problems. It's just there. We see it. The patient doesn't see it. But when we look in there, it kind of freaks us out a little bit. The other one that is pretty important is conjunctival hemorrhage. And what this drug does is it really works on lowering episcleral venous pressure. And when you lower your venous pressure that dramatically, you're going to get some blowouts and you're going to get some petechial hemorrhages. So these aren't like the large bullous, conchemes that you're used to seeing in clinical practice. These are really small and you can really only tell. It looks like hyperemia, but when you get behind the slit lamp, you can see these little petechial hemorrhages. Those are usually gone within the first 3 months if they happen. But the last couple I'll talk about, blurred vision has been a big one. When I say, 30% get serious hyperemia, there's another 10 or 15% that get a blurry vision. They get a loss of 1 to 3 lines of visual acuity. And I've experienced it numerous times. And about the only thing you can do is discontinue the medicine. Again, I see people with verticillata that have no blurry vision. I see people with blurry vision that don't have verticillata. So that's another one. And finally, erythema of the eyelid. I've had 2 or 3 patients that have had just like the brimonidine type of reaction, the alpha-GAN type reaction where they get really red and crusty all the way around the orbit and the adnexa. So just be aware of those. But when it works, it's a godsend. I'm really glad to have it in my armamentarium. I just know that probably 50+% of the time, I'm not going to be able to use it. Here's a look at the verticillata. It's usually, this is the amiodarone one. This is one that came out of the clinical trials with rho kinase. And you can see that it really occupies the lower 1/3 of the cornea. Very rarely do I see it ferning up towards, the central or peripheral cornea, really in that lower 1/3. Then they have the product where they combine it with latanoprost, the Tarsadil plus latanoprost. And you can see, again, 63% hyperemia, not surprising. When you add a prostaglandin to this, we're going to get even more hyperemia, but everything else was about the same. These are what these little hemorrhages look like. They're right on the limbus. They almost look like little pigmentations that someone would normally have. And then there's that. So in my last 10 minutes here, I think I want to talk about SLT. I brought it up that's 50% of my new starts. I hope to drive towards SLT, not only for the efficacy and the lack of having to use drops and the side effects and the expense, but it is a procedure that for most patients is completely covered by their insurance. It saves the system so much money. I think we get reimbursed about $280 for an SLT. Do you know how much it costs on average for someone to have a single medication, glaucoma medication per year? It's like $800 to $1,000. If you have them on 2 or 3 medicines, we're talking, double or triple that. So for $280 to be able to control somebody for 5 years is pretty good. So, what helped besides the fact that I can perform it, that I do it, I have confidence in the results, is that we had this study called the Light Study, and it was done in the United Kingdom. It was published a couple of years ago. And what they did, all the major hospital systems that had eye clinics in England participated, and they got 1,235 eyes from 718 patients, and they were randomized 1-to-1 to receive SLT or drops. And I won't get too much into all the entrance criteria, but you couldn't have like end-stage glaucoma to be in here. You had to have no surgery except for cataract surgery. And they used HRT, not sure, I guess in England, they still used a lot of Heidelberg HRT instead of OCT. Would have been nice to have an OCT component to this, and then visual field. And for medications, they were allowed to use first-line beta blockers, prostaglandins, second-line beta blockers, and third lines CAI or alpha agonist, and you could use maximum medical therapy. So after the end of the 3-year period, what they found is 95% of patients that were randomized to receive SLT were at the target pressure. And out of that, almost 80% only required laser, and 76% of those only required 1 SLT session. So out of all the eyes treated with SLT, 3/4 of them are still controlled at 3 years with 1 SLT session. And only about 20% of patients that received SLT required adjunctive medication at the end of the 3-year study. 93% of the eyes that were treated medically were at target IOP at 3 years, and a little over close to 2/3 were using a single medication. And at 3 years, you can see that the target IOP was obtained about the same for SLT versus medication group. In terms of progression over the course of the study, 36 eyes in the medication group show confirmed progression, and only 23 eyes in the SLT group. None of the eyes in the SLT group progressed to need a tube or a trab or some type of invasive glaucoma surgery. And around 1.8 or 11 of the eyes in the medication arm did require surgery. So anyhow, the side effects, no IOP rise, only 6 of the 1,200 and something eyes had a IOP elevation after SLT. And from that, they determined that the 2-week or 3-week follow-up, just to make sure they haven't had an IOP spike, might be an over recommendation. I certainly keep my patients in the office for about an hour. I usually find if they're going to spike, it's within that 30 minutes to an hour after the procedure. Of course, we use bromonidine to blunt any IOP spikes pre and post-op right in the office. But still, if you're going to have one, I think it's in that first hour. So I really try and just monitor and do my due diligence there. So what they found was that when you use SLT in lieu of eye drops, the approximate savings about $450 per patient. And when they kind of added or aggregated all the savings that a patient might experience, the cost savings that SLT provided versus medication was enough cost savings to provide 2 other patients SLT. So again, it's very efficient for the system. All right. So with that, my last minute or two here, what should you expect, kind of in summary after starting a glaucoma treatment? It doesn't matter if you use medication, laser, whatever you're going to use, a bare minimum has to be a 25% reduction. I mean, when you look at clinical trials in pharma for glaucoma, they have a non-responder rate. That means in the study, the patient was considered a non-responder if, and it depends on how you set that criteria. Some studies it's been 20%. Some studies it's been 25%. Some studies it's been 30%. For me, I think if you're under 25%, you're a non-responder. And I think if you're over 40%, you're a super responder. And everyone else in between is 25 to 35%. So that's always just like, take that to the bank. In the rare case when it doesn't happen, sometimes I find that people that are non-responders to PGAs aren't great responders to laser either. Or people that start with laser that don't have a great response, sometimes they're not great responders to PGAs on the flip side. So again, just be cognizant of that. If you have one failure, don't give up. Don't think, well, PGAs don't work or SLT doesn't work or that doctor doesn't know how to do laser or whatever the case may be. Generally speaking, they work well. So if you started with a generic, if you don't get to the target pressure you want, you started with a generic PGA, try a branded one before moving on and adding something. Very common. I do it a lot. If someone's on a branded one and I'm not getting what I want, I'm going to probably try another branded one before I give up and just start piling on a bunch of other old medicine. If you started with drops, try SLT next or vice versa. And then for me, I want to think about what I'm doing. And this is getting a little ahead of the initial treatment. But when you start thinking ahead to the future treatment, I need to add something. What am I going to do? Well, if you're on a prostaglandin, that's helping uveal scleral outflow. If you use a beta blocker or an alpha agonist or a topical CAI as your next add, well, we know that that's going to reduce the production of aqueous fluid. So it is a different mechanism than uveal scleral. If you're going to do SLT, that's trabecular outflow. If you're going to use a Rho kinase inhibitor, that's working on trabecular outflow. So you want them to be complementary, meaning don't put them on 2 or 3 agents that reduce aqueous production and not do anything with the outflow. But on the flip side, if you've exhausted the outflow pathway, think about adding a drug that is going to be complementary with a different type of mechanism of action. And I'll kind of leave you with that in case you wanted to see a confusing thing. And then lastly, I get this question a lot. I have a patient on the drop. What do I do next? Like to me, this is our bread and butter. Making the diagnosis and starting treatment is number one. Number two is trying to determine if that treatment is enough to keep them from progressing. And for that, I do a pressure check every 4 months. If they have advanced glaucoma, I do it every 3 months. At least once a year, I'm doing a visual field and an OCT. And if I feel like I'm seeing progression, I feel like something's changing, I'll do it twice a year. I'll do it however frequently I need to take care of that patient. And again, so it's looking at the structural damage, the progression, and then it's looking at how is my treatment doing? Am I at my target? And is that target keeping me from progressing? And that's, to me, the first 50% of treating glaucoma.